Thank you very much for this kind. Thank you very much to Fatty Liver Alliance for organizing this and for inviting me. I'm really honored to be here to support this and really love to see this outreach towards primary care. So I want to reiterate a little bit what is the first session about. So we'll focus, Jeff, Lazarus, and me on epidemiology about NAFLD and NASH, and also how do we classify it, and around prevalence and risk factors, and also look about what are the comorbidities and then what are the clinical consequences. So it's sort of, let's say, something that covers a little bit of everything, and then the next sessions will dig deeper. That's an easy flyover, I guess. But I want to start off with that we always talk about something, but how many people in primary care have actually animal? I think many of us hepatologists in tertiary care, we see it a lot, but what does it actually look like? So this is a picture of healthy liver, and you can see it's beautiful. It's clear how it's all well organized and nice. But what happens with this disease? And I think this links very well to understanding why this is actually serious and have consequences for the patients. So this is what it looks like with steatosis. You can see also the holes in the cheese here. That is where there used to be fat. That is then removed when you do the preparation. And then if you can see my pointer here, this is inflammation in the liver. That's what we call steatohepatitis. And it's clearly that this liver is not doing too well. But what actually steatosis inflammation leads to fibrosis, and that's what drives morbidity and mortality and what we want to prevent. And that looks like this. If you remember the first picture, this liver is clearly not doing well. So all the red thing here is scarring of the liver, and scarring makes the liver non-functional. And this is associated with high morbidity and mortality, and this is exactly what we want to prevent. I'll discuss a little bit how we actually can do a lot, but we're still awaiting, let's say, very specific therapies that can prevent this from happening in the liver. But before moving on, so I love your title, but yet we have to acknowledge that we cannot really say NASH or NASH. So I know that Professor Ranella will dig deeper into it, but I actually would like to open it a little bit now, because we need to acknowledge that after 3 years of work here, it's Professor Phil Newsom presented at EASL Congress in Vienna 6 months back, the new nomenclature of fatty liver disease. So we don't call it fatty liver disease anymore. We call it steatotic liver disease. And it was just to say, so I will use that labeling. I'm sure most of my colleagues will too. So without going deeper into it, so now it's not fatty liver disease, that is the umbrella term, but falls over a spectrum. I'll get a little bit back to that. So a spectrum where we have here on the left side what we formerly called NAFLD, now it's MASLD, and then down here NASH. And then we have other parts of the spectrum that involve also metabolic factors and alcohol. And again, important things, because in the clinical world, there's often an overlap in patient can. So just to make it easy, if we go up here, so NAFLD become MASLD. NASH become NASH, just to make it easy. And again, it's also not just involved a new name, but also a new definition. And the way we approach, and I think that's again important for primary care, we start off with hepatic steatosis, something you can see when imaging, get an ultrasound back, there's steatosis, or you do a FibroScan. And then if there's more factors, one of these, then we call it MASLD. So this is sort of the innovation, is where it's better reflecting disease etiology, non-stigmatizing. All of these things Professor Ranella will come back to, but just that I'll use this new terminology, since I think it's important we all speak the same language and we sort of embrace this, because it represented a huge step forward. It's also important to say that this does not mean that all the literature that has built up in the last 2 decades that is really important for our current understanding is outdated. Because if we look at the spectrum there only with MASLD, then actually MASLD equals NAFLD almost 100%. So this is still works, and the same with MASH and NASH. Okay, epidemiology. How big is this problem actually? Why is it we should take this seriously? And why are we more serious now than 10 or 20 years ago? That's, I think, an important question. This is a recent publication across the world. And you just look at it integrated, roughly, let's say a third. I would say a third many times in this, I remember. And then it doesn't matter, it's super correct. But roughly a third of the global population have too much fat in the liver. The picture with all these holes in the cheese. And that has some consequences. So I'll come back to that. But also we are witness at development. So 50 years ago, it was probably not at all like that. But just in these 20 years period, you can again see there's an increase in the prevalence of this. And this is actually sort of also mirroring the development we have in the obesity and the diabetes epidemiology across the world. Basically part of the, let's say, the same integrated what was metabolic syndrome. If we then go into specific risk groups, which I think is very important, and there will be people later talk about how do we actually diagnose and what do we do it and should we screen specific population. If you look in patients with type 2 diabetes, here in this meta-analysis, more than 50% have it, and it's probably even high in some populations. But we can go into the prevalence of different things here again from another population. Again, if we look at the type 2 diabetes population, in this paper here and also recent meta-analysis, it's almost 2/3. But if you look then in those with type 2 diabetes, how many have NASH, so the inflammation part in the liver? We're also close to 1/3. And if we go of those we know have fat in the liver and have type 2 diabetes, yeah, then it's almost half that have NASH. So this is really important, and also tell that this is not needles in the haystack. A little bit further here is again, if we look here as patients with NAFLD, what we call them, how many actually have advanced fibrosis, coming closer to the last slide I showed with a lot of scarring in the liver. You can see here, if you do liver biopsy or you do a FibroScan, it's actually around these 17%. And the same here, if you look at population where you already know they have NASH, it's actually a significant proportion that have these. So it shouldn't be too difficult to find, and yet this has important implications for the patients. But it also means it's a societal challenge, and why this awareness and what we do in policy, also in societies like EASL and EASLD and many others, trying to push this from society, because some will have this fat accumulation I show in the picture, some will develop NASH, some will develop fibrosis, and some will develop liver cancer. And again, if you have all these, even the percentages of the fraction become smaller. If the multiplier is 1/3 of the global population, this poses a significant threat or burden on the healthcare system. Later to explore how we actually going to tackle that. But it's just to say that this is the trajectory, and it's difficult to predict which specific trajectory individual patients take. Yet we know that on average, patients, if they have one fibrosis stage, it probably takes 7 years to move to a next stage. However, within that, there are always variations. Most may progress slow, but we also know that there's a group that actually progress pretty fast. Those we need to look out for and take specifically good care of. And then again, back to the societal channels. This is from EASL Lancet Commission numbers in Europe. Now, prevalence here in Europe, 148 million people have too much fat in the liver. It's associated, again, if we look here to, as we can bestly estimate, 862,000 patients with cirrhosis due to NASH. This is not something you can transplant your way out of. And also massive, let's say, socioeconomic burden in terms of impacting total years of life lost. And again, a similar scenario here, comparing 1990 with 2019, you can see across all these different things, there's a clear increase. So it's a societal challenge that we need to respond to. And I think we are responsive. But it's certainly also, let's go closer to the doctor, to patients' clinical challenge. Because where do we actually see these patients? How does this unfold? So this table here is describing the natural history of the spectrum of liver disease, how it is. So the top one here is the natural history. We have disease progression here. That is actually progression over a number of stages. And some of them in the first many years are asymptomatic, meaning that these patients don't come and ask because they have no symptoms. And yet, if we look at the time frame here, the mortality in the early stages, it's slow progressing over decades. Mortality then increases, and in end stage, mortality is very high, where we cannot do much, or even if you pick the right, it's transplant, we cannot transplant our way out of this. So this is important. And that's also why the places where we do these different non-invasive tests that other people will talk about is in this space. So how do we best apply them? So the bottom line is here, we understand, let's say, liver diseases horizontally. They progress over stages, and actually, if we do initiative, we can halt this progression or we can revert it, and we have different tools. So we understand it horizontally, but we navigate it vertically, going down here to diagnosis and further down here to treatment. And again, more people later will talk about this, but I think it's important to have this framework that they're under the radar with no symptoms and should be diagnosed correctly. This is just development in transplant, so it has consequences, real consequences at the moment. The top one here, you can see this one is associated to MASH. It's increasing, alcohol is still leading. You look at the dark one here, you can see this is then the percentage each. This is one is taking off. Another important message from this one, the red line here, that is hepatitis C. So it tells us if we have effective treatments, then the consequences of patients, they change a lot. So you can see we're almost getting out of transplanting hepatitis C because we have effective drugs. That's exactly why we want to look for and strive for effective drugs in this space, because it can change the life of real people, real patients. A little bit back to the comorbidities. Again, these are not seen in isolation. So it's again a human being here, liver here, insulin resistance, etc. here. So again, I come back to my thirds. If you have a patient with NASH, a third of them roughly will have obesity, diabetes, dyslipidemia, something like that. And then if you look into specific populations with NASH or with obesity or type 2 diabetes, also rough NASH. So meaning that they're right under our nose. We just need to be better, in particular when we have something more specific to do. But I'll show you already, and other people come back to that, we can actually already do quite a lot, and we should do that. So this is a conceptual way of understanding it, that I will call dynamic spectrum of diseases. And this is actually trying to integrate both the cardiovascular risk and the liver-related risk. So we are more in this spectrum, but more people than we think actually consumes a certain level of alcohol, and that impacts their risk as well. And then we have this, some are modifiable, some are not yet. For instance, genetics, we traditionally didn't consider modifiable, but drugs are underway to impact genetic drivers. And then, but let's go back to this one, the spectrum here, and then the severity of disease up here. And then we can see, if we go down here, the ratio for cardiovascular versus liver risk is probably 1 to 4 times other liver-related risk. So where we can put patients into this matrix and see what are their risks. But important thing is, I think down here, what we have now do with risk modifying interventions? And there are a lot of things we can do there. Let me just wrap this up in this final slide here. So what we can already do, what we have now, is control of these comorbidities to make weight control. We have several interventions. If there's alcohol, we also have intervention if they have viral hepatitis. And these things are important because if we have a disease that captures 30% of the population, then if we capture somebody with viral hepatitis, they might likely also have this one, just like also most people consume alcohol. So remember to see this in an integrated way. But then I think I will end here and thank you very much for your attention so far.